Yes. Hi, welcome back. We are moving back to 585. And, I'm sorry, I'm doing a little housekeeping while we're on here. Do you think you should come up for, we don't have any changes, do we?
I mean,
Oh,
you talked
do we have
about-
changes? Or no? Let's,
What are you at? I don't know where you're at.
okay, okay. We talked about the language. So what I want to start with is I actually want to start with Blue Cross Blue Shield. Courtney.
Oh.
So couple pieces in 585. We're not going to do sections 1 and 2 again. I believe you've already testified on those. You're clear on yours. I had asked Blue Cross to come in and share thoughts around the prescription drug cap and sort of what their comments were around that, since ultimately they are the ones that have to come up with the menu. And I just wanted to maybe get a little bit more information on the site neutral around Blue Cross Blue Shield. So Courtney, if you wanted to go ahead, do you have anything to share with us? Documents or slides or anything?
Nope.
Okay.
I'll be, for the record, Courtney Harness, Blue Cross and Blue Shield of Vermont. Nice to see you. Thanks for not asking me to talk about sections 1 and 2. Spare you the same thing on repeat. On the prescription out-of-pocket maximum, I'm going to take my phone out because I want to read just a line or two from our chief actuary, only because she's much smarter than me and it seems to make more sense to do that. One, Eva did submit written testimony for today. We would seem to align pretty closely with that testimony from the perspective of the timeline of 2028. Also, some good information that was shared this morning around what those out-of-pocket maximums are. And it was nice that someone got to do all of that math. It wasn't me this morning, but we do have the math. And so I think when I was in a couple of weeks ago, what I did mention to the committee was that we don't see that there's actuarial value in this decision, nor would we see any movement on premiums. I think what I did share was that especially some of our large groups would appreciate the flexibility in plan design that this brings. And so what we would have to do essentially is navigate some of the cost share issues that come up with the out-of-pocket maximum to make sure that the actuarial values can be certified on plans. And so did have some conversation with the healthcare advocate. I do believe that, we might be able to offer a few different plans. Again, a lot of that is up to our regulator. We can work with them to design plans that we do need to submit for approval. And so from that perspective, I would say the only issue that I would see, and this would be one for Vermonters that we worry about, if we're designing one plan with no out-of-pocket max and one plan with an out-of-pocket max, if we have, and again, this happens in other plans now, so I'm just kind of laying it out there, we would potentially see someone choose a plan with no out-of-pocket max because of a current situation when they choose the plan where they're not using a lot of prescription drugs that then may end up with a $20,000 price tag. Again, that happens with plans that we offer now, so it's not like that doesn't currently exist. So I think the language of the bill does offer some flexibility in plan design, the proposed language. Again, we don't see this as something that has an effect on premiums, but we do see it as something where Vermonters could potentially have some flexibility in plans that they could choose from. And to Diva's written testimony, looking out to 2028 probably.
So we talked earlier today with Ledge Council. The bill as the latest version of the bill has essentially just striking out the requirements. What if we kept the requirements, but then we went in and we gave mission to not only do it for the bronze plan, but that you could create other plans at other metal levels that have an equivalent out of pocket for both prescription and medical. Would you pursue something like that?
Yeah, and good question. And we've had some meetings with a DFR in the last couple of weeks where we shared some data and research around all metal level plans in New England and kind of where Vermont falls and what some of the issues are, mostly in a conversation that we can walk down on how we get more creative or innovative with plan design, particularly to focus on affordability. And so I think that that was a good first meeting, but there would be no reason for us to say, no, don't let us have more flexibility in plan design. I think we would welcome that.
Go ahead.
I don't want to get into this today, but you just thinking about it. Is there any tracking of utilization of, like, in terms of these benefits? Like, is there any way to look at, or for us over time to monitor, or does Green Mountain Care Board do this already? Just how people are utilizing, like, prescription versus general, in other words, like how many people are reaching their deductible, how many people are maxing out their cost sharing, and like, what is it on? Like, is that data collected and managed and reported in any way, or?
Yeah, that's a great question. I think I saw in the Healthcare Advocates written testimony, a couple of questions to that. So I think if the committee wants us to look through that specific set of questions, which if I remember correctly, was around percent of people that reach their maximum. And there were some great questions in there. So if the committee wanted us to come back with that information, we could.
I'm not asking that right now.
Okay.
I don't want to make people do work. It's just maybe someday it's worth looking at. But as you speak about plan design, it makes me think about when we're designing these plans for people, like, how do we take into account how they're actually using them?
Yeah, and I think this morning, I heard a couple of folks on the committee say that it's kind of scratching around the edges, but the real
Yes.
meat of it is in reducing the cost of
Yeah.
care. And if we want to see real downward pressure on premiums, then we have to continue to focus on not just the cost of care, but the cost of prescription drugs themselves.
Thank you.
Well, I think that coupled with some flexibility in plan design would be really beneficial.
And I think that's why I asked about how they're using it, because then it's like, what are they actually spending money on? But I think in general, we need to reduce costs. I think we all agree with that.
Okay, let's,
I was just waiting to see if anyone. This section in the bill now, the way it reads. The health insurance plan shall not include an annual dollar limit on prescription drug benefits. Does this have any impact on any of the contracts that have been negotiated through the unions?
It's a good question. I have to go and find out. I would say, and thanks for pointing it out, that language as it is right now, as you just read, doesn't give us an option. So that would just be, we can't. So if there are any contracts that we would need to look at, it would be because of a change to the law. So I think we would have a good reason to go back and do that.
so actually, that's a great question, Tucker. I wasn't even thinking about it in the terms of, let's say, because you administer the state employees,
Yep.
you administer education benefits. So with those plans right now, you're not able to offer a plan with um, a combined out of pocket, correct? You have to abide by the lower for prescription and generally higher for the medical.
Mhm.
So if those self-insured groups were able to offer an additional plan and maybe not so much state employees, although their cost share is also pretty minimal, but particularly the teachers, where it's the school district who's actually picking up their out of pocket. Would that have an effect if teachers were able to choose different plans based upon their utilization of healthcare?
Yeah, I think, like I said, not an impact on premium, and the large groups, and those are ones that you all named are large groups. They would certainly appreciate the flexibility. I think I did see a letter come in that was maybe not appreciative of the flexibility from a large group, but to that point, there's less flexibility in the way that Vice Chair McFawn just read the language around shall not. So that's not.
Just for the legislative council, so the language around shall not is existing law around annual dollar limits. There's no affirmative shall not have an annual out-of-pocket max.
Perfect.
It's just the language you saw before that strikes the requirement for. So, but that's not what was just suggested, so I want to.
Thank you.
Okay, I think maybe I misinterpreted then. Okay. Thank you. Any other questions or comments? Let's move to site neutral.
Sure. So had some good conversation with folks from Rehab Gym actually in here earlier during a break about their letter in addition of occupational therapy and athletic training, which are typically all grouped together under, I think the term was rehabilitative services. There's no issue from us if we wanted to go ahead and do that. I would say probably easier to do it as a whole group of services than to try to pick out. So I think that that's a great suggestion to do and probably gives us a little broader cross-section for when we come back to committee with a report next session.
I have a question for you. So let's say we're calling it site neutral, but it's really sort of eliminating a hospital's facility fee, correct? In addition to their, no,
I don't think so. I think that's been the clarification.
okay,
Jump in.
no, please, jump in. So how do we have it current in the new
I
draft?
mean, I didn't have to let Courtney address that, but it's been, people mean different things when they say site neutral. And that's the version that isn't the bill is saying the facility fee. It's saying it has to be the same professional fee.
Okay,
It's outpatient fee schedule.
okay,
Yeah, my understanding of it was that it was the responsibility was put on the payer to determine a set fee schedule across regardless of the location, so that there would not be independent professional outpatient. There would be
Okay.
one.
there would be one.
Yep. I would say, and I could be wrong, and so maybe I didn't look at the draft from this morning. I wouldn't suggest that we would ever do this. However, I think the current language gives a lot of flexibility to choose whatever we want. And if we for some reason did decide to do the thing that we don't always do, we could potentially set a price that doesn't really help anybody, or set a reimbursement rate. So I'm not suggesting that we would. I'm just saying that the language in there currently does give a lot of latitude, which we appreciate.
That was actually my question.
Okay.
Which is, if you're paying the same rate to everyone,
Mhm.
the assumption would be that because right now you're paying one here and one here, can we be assured that if everybody's coming to the same, that you're not gonna go from here to here? Can we assume that there is room that you're going, if you're saving a tremendous amount?
Yeah.
Can it be assumed that you're going to amp up your reimbursement rates?
Yeah, 100%. I think the assumption would be is we would look to find a place where we could bring up the independent professional fees a little bit and bring down the outpatient fee. I think that's the goal of the language of the bill. I think it would be safe to assume that we would do the right thing. So yeah.
Get 2 new board members. I'm sorry, that was meant to be funny. It wasn't meant to be anything else. Okay. All right, yeah, I mean, I think that the site neutral section, particularly around physical therapy, is because the disparity is so great. And it's obvious that the disparity is so great. And I don't think we're using this to try to, save Blue Cross Blue Shield buckets of money.
Right.
I think what we're trying to do is we're trying to set the precedent that these are equivalent services and they should be paid at equivalent levels. And the hope is that you would pay everybody adequately.
Yeah.
A fair reimbursement for services.
Yeah, I think our goal from this and in partnership with you all is to come back on the reporting date and show some really good positive results that can hopefully use this as a nice springboard into some other areas. So absolutely.
Thank you.
All right.
Oh, Tucker has a question.
On page 19, line 12. Is that just the reimbursement, plan may reimburse different amounts for physical therapy items and services delivered in an inpatient setting? Is that going to stay in?
Yes, because we're talking about outpatient services here. So that language allows them that if it's in an inpatient setting, that it can actually, because it's not an equivalent service to another outpatient.
Okay.
Because the person's,
So it's going to stay in?
yeah. This just is making it clear that we're talking about outpatient equivalency, period. Go ahead.
So on site neutral, how do we best determine, what's the appropriate level? What's the process?
So the goal, frankly, for us would be to find a happy medium where you all, by way of this bill and us, in hopes of finding some cost of care savings to put downward pressure on premiums, can figure out a place where we're elevating the lower reimbursed services and bringing down the higher reimbursed services to realize a savings and also create some parity, I think. Yeah.
Any other questions? Yeah, go ahead.
Just a clarification from what Topper said, because, so outpatient, inpatient is a nursing home? Where, like, if you have a stroke and you go to a nursing home and get your rehab, how does that fit?
Inpatient, so it's tricky because it's not, inpatient is not in the hospital technically, whereas outpatient can also be in the hospital. So, inpatient might be a physical therapy service, after, or a physical therapist providing a service post-surgery in a hospital bedroom. Where
Inpatient.
yeah, outpatient would be, I go into a hospital, or it could be, I go into a hospital to receive my physical therapy and services in a physical therapy office that's located in a hospital or some other site around the state, right?
Great. Thank you.
Thank you.
Okay, since we're talking about the Charlie. I'm working on an old schedule, so I'm just like looking around the room.
Thank you very much for having me in, and I'll try to be quick because I see you have a lot of people here that you need to hear from.
Yeah.
So, yeah,
You're gonna talk about the out of pocket.
I am, correct, yeah.
Okay.
So I just have a little bit here. Thank you for reviewing, for the record, Charles Becker of Office of the Healthcare Advocate. Thank you for taking the time to review our one pager and for allowing me a few minutes to speak with you today. I want to acknowledge that with this bill that you're considering, 585, you're looking for ways to make healthcare less expensive for Vermonters. Healthcare is expensive. Vermonters are struggling and they need relief. We all share that goal. And it's been identified that there's this thing that we have here in Vermont, this prescription drug out-of-pocket max, and it requires all or nearly all state-regulated plans to cap prescription drug costs through this low threshold. Currently $1,700 for an individual or $3,400 for a family, whether or not a person thinks that they or their family need that type of benefit. And I sense that there's a perception that this cap is a benefit for some people, but not for all people, and yet it raises the price for everyone. I would say that this RX prescription drug out-of-pocket max is a benefit for all Vermonters, actually, and for reasons that I'll get into in a little bit. And I would say, as far as how much the prescription drug cap raises prices on everyone, I would say that that could be answered with an analysis, but that we don't know the answer to that already. And I think we just heard a bit of information from Mr. Harness that perhaps the impact on premiums are not that significant after all. I also have a sense that there's a question lingering out there. Why is prescription drug spending different than medical spending? And why are we privileging prescription drugs over medical care when, after all, it's just costs to Vermonters? And I also wanted to make an attempt to answer that question. And I want to make a comparison to preventative care. I would say one of the greatest accomplishments of the Affordable Care Act was the preventative care mandate. Zero cost share preventative care, and not just for ACA plans, but all plans. Every non-grandfathered health plan in the country must provide zero cost share preventative care to beneficiaries. Screening colonoscopies and mammograms, pap smears, lung cancer screenings, many other services. These benefits cost everyone money, though not everyone may use them in a year. And there's a very strong policy reason for that, right? Because preventative care saves money in the long run. Keeping people healthy, catching disease early, those things save individuals money, and it saves the system money. So I'd like to suggest to you that the same concept applies to the prescription drug spending, and that this prescription drug out-of-pocket max, it serves an important function that does benefit all Vermonters. When a person is diagnosed with an illness, particularly a chronic illness, and maybe they've spent months or years and many thousands of dollars trying to figure out what condition it is that they have, and now they have this diagnosis. You have X, cancer, multiple sclerosis, HIV, Crohn's, diabetes, asthma, you name it. You have this condition, it's incurable, but there is good news. You can regain your health, or you can preserve your health, prevent the progression of this disease. You can stay healthy longer. All you need is a prescription drug. And that's good news for the individual and their loved ones, that if they can afford this prescription, they can stay healthy. And that cap helps people to afford their prescription drugs. But it's also good for the system. Ensuring that people diagnosed with chronic illnesses can afford their medications to maintain their health, to prevent complications, to avoid unnecessary hospitalization, that saves money for everyone. It's also the nature of the spending that's a little bit different too, right? When you go to when you pick up a prescription at the pharmacy, you have to pay right then and there for that service at the counter in cash or with a credit card. With a medical situation, you have a medical emergency, you break an arm, you have a heart attack, you'll go to the doctor, you'll receive your care, and you can sort out paying for it later. That is not the case with prescription drugs. And so that is why we think prescription drug spending is different, and why preserving this prescription drug out-of-pocket max for everyone makes good sense policy-wise, at least, and at the very least, until DVA or the carriers, as they've said that they're willing to do, come forward with an analysis showing that repealing the cap will actually allow for meaningful, impactful plan design changes that would really make a difference in making health insurance more affordable for Vermonters. Even then, we'd want to preserve the cap for some, as I've heard you suggesting you're open to allowing, having some plans have the cap and have others not have the cap. We would want to preserve the cap in some form, even then. And so really, that's our HCA request. We don't think there's been a strong enough of analysis of this issue yet. And we'd urge the committee to request that additional analysis and to maybe come back and consider this matter in another legislative year.
The last thing you said, did you just say like, can you say it again? Like your final summary of your recommendation, like, are you saying we should wait and study it more? Or are you saying we should do it and study it more? I missed something.
Okay, the RHA position, the RHA position is that this cap has value for Vermonters and we'd urge you to keep it.
You mean like, don't strike out all this
Do
language?
not repeal it. Do not repeal it.
Okay.
Yes.
So in other words, don't do this section of the bill.
Correct.
Okay, thank you. That was what was not, I wasn't sure where we landed, or where you landed.
At the very least, come back, ask for more information and come back and look at this another time.
Or change the section of the bill to say, come back to us.
That's what I was thinking. Okay,
Okay.
I have another question. I just wanted to clarify, because as I was thinking of the other question, then I was like, what did he just? So thank you. And it is what I thought you were saying. So, you mentioned in your testimony that the Affordable Care Act established like a right or requirement around preventative care.
Mhm.
Does that mean does that include your yearly physical, or is that only the diagnostic testing?
The preventative care is for screening.
Screening.
And I believe it includes an annual wellness exam. I'm not entirely sure if that, what.
Okay, the reason I ask is because when did the Affordable Care Act go into effect?
2013 as well.
I pay for every
Yeah.
yearly exam. They charge me something, so they're clearly finding a way to bill for something. It's not free for everyone. But we don't need to get into it today. When you said that though, it kind of threw me for a loop. I'm like, wow, really? Okay.
I'll talk to you about significant, separately identifiable at some point.
So what's that?
Never mind.
Oh, ways that people bill for things? Yeah.
To further Brian's question, because I've been. We assume, and we've been under the Affordable Care Act for how many years now?
15, 16?
16 years. And we have all these preventative services, all recommended, the A&G from the US Preventative Services Task Force. Do we have any evidence whatsoever that our concentration in the last 15 years or 20 years on providing preventative services has actually made Americans healthier and brought down the cost of care?
I would have to come back to you with information on that. But I did provide 2 citations in our one pager to, and I believe Mr. Hage in his letter to the committee as well made citations to studies that suggest that when people are able to adhere to their medications, that their costs of care are lower, that they have better health outcomes, they have less unnecessary hospitalizations, and that their total cost of care is lower when people are able to adhere to their medications.
Do you think people often or sometimes have a propensity to choose prescriptions that are higher cost ones because they know they're going to meet their out-of-pocket max anyways, and that they won't be on the hook for that $2,000 a month prescription?
I don't have any sense of whether or not that's something that people do. My sense is that people make decisions about the medications that they're going to take with their doctors based on their conditions that they have. I don't know that people are making decisions to take more expensive medications because they know it's going to get them to that point of pre-healthcare. I don't know if people are making those decisions. So I couldn't speculate.
Yeah, go ahead, Beth.
Would it raise costs for the chronic conditions? Have prescription medications for chronic conditions?
Repealing this cap as proposed in 585 currently? Absolutely it would. For the person with a chronic condition, they would potentially be exposed to those full out-of-pocket maxes that are referenced in DIVA's written testimony that they submitted to you and that you've seen going around on this placemat, that potentially, $10,000 for an individual, $20,000 for a family. That could be your exposure. You could go from being exposed to $1,700 in annual prescription drug costs to being exposed to $10,000 on an individual level. It absolutely would cost people with chronic illness money.
Okay. So just be full transparency. I'm the one that put this in here. I've been talking about this for years. So right now, and I'm looking at the menu, if I have Blue Cross Blue Shields and I am able to afford a family gold plan. So a family gold plan, I am paying $3,780 a month. Okay. So if I happen to have, if my costs are mainly incurred with a prescription, my out-of-pocket max for my family is $3,300. If my family incurs their medical care, their expenses through medical care, let's say your 12-year-old child ends up with appendicitis and has to have surgery. That family's out of pocket is $11,400. So a difference of over $9,000 that one family would pay for their care as opposed to another family who equally health conditions or not equal health conditions. So to me, it's almost an unfair thing because it's almost like pitting people's health care against each other and who's more valuable and who's less valuable. So would it make sense if we allowed, say, plan designs around gold to continue to have a cap on one plan and a more reasonable out of pocket, because it wouldn't be $11,400. If you merge them together, it might be a little lower. Same $3,800 a month. And, we keep talking about age rating. If I'm a family of 4 and I'm in my 30s and I've got 2 little kids, the odds of our medical care being generated from prescriptions is probably a lot lower than if I'm, say, my age. And I, have, as you get older, you have more chronic conditions. So aren't we sort of relegating younger people to pay more so that older people can have a lower prescription drug? And
Madam Chair, I understand what you're saying. I do understand what you're saying. And I've been listening to your committee's testimony about this throughout this entire time. I know this is one of the reasons why you've brought this section of the bill to this committee for you to consider. I would say to you, I think it might make sense to do that. It might make sense to allow the flexibility to offer a gold plan that doesn't have the prescription drug out-of-pocket caps. out-of-pocket cap, but I don't think this committee has seen the information to say that that would be a good thing to do.
I agree.
So, and that's what I would say. And it would be the extra benefit to that family who has the medical expenses over the prescription drug expenses. I'd want to know, like, what is the magnitude of that benefit? Are they going to get $5 in extra deductible protection, or are they going to get $50 of extra deductible protection? $500? How much more protection are they going to get for the sacrifice of giving up this benefit for all Vermonters of this prescription drug cap? Because it is, I would say, a benefit for all Vermonters, even if you do not take prescription drug medications. Again, because a healthier society is better for everyone.
Great.
Thank you.
Thank you.
Thank you.
Thank you. Okay. Let's move on. Yeah. So,
No, not for you. I'm
Okay.
thinking about our next step. So what happens here with this language? What do we think?
we're still talking about the bill.
We'll have a discussion
We're
later.
gonna have a discussion later. We're gonna, you know what we're gonna do? We're gonna have a long discussion tomorrow. We're gonna put it in the morning because, and I don't think Jen needs to be here. Yeah, I know. I know that. She's so yeah, we're gonna do committee discussion on this tomorrow because we got time. Thank you.
We don't now,
Unfortunately,
yeah.
unfortunately, we don't have time. All right. Hi.
Yeah.
You're here to talk about some of the things we heard or some of the discussion that we had this morning. That's it. So let me ask you, first of all, if you are fine with us leaving that the governor gets 2 picks as originally written.
Yes.
Okay, thank you.
Can you repeat that?
Okay. In section 1, around the governance piece with Blue Cross Blue Shield, that we had been going back and forth on whether the governor gets 2 picks. And it was originally written that the governor gets 2 picks, and the new version has still the governor gets 2 picks. And Commissioner Sampson is fine with that, he just said.
Correct.
Great. Let's go to association health plans.
Yes.
Wondering if you were able to see any of our committee discussion and the new language.
Yes, so that's what I'm mostly here to talk about. But obviously any questions you have. I did see portions or get summaries of this morning's discussion. Couple things I want to point out. I'll definitely talk about the data, request for data. First is that the plan as we presented it has 2 components. One relies on a change at the federal level, or equips us to be ready to conform with what could be a change at the federal level around the commonality, who can form an association health plan. That may or may not happen. There's a second piece in there that I didn't hear talked about this morning, that is about an association health plan must conform with what coverage benefit requirements. Currently, it's small group. We're saying so the second piece is to allow conformance in our law with large group for an association health plan. So the delay, if ultimately this committee decides they want to delay or go with this amended language, I think there's a second question of like, what do you feel about the other part? The change in requirements of how an associated health plan complies with our law, small group or large group. So that's, I'll pause there.
We had discussion around not only the language around the pause, but additionally that the Department of Financial Regulation would come back to us with some, I guess I would say, data on, the effects of this on the QHP market, effects of this on the large group marketplace. lots of other things we had, and I can't remember all of them.
All I had was the impact on the individual and small group and premiums.
So in regards to data, what will be the impact of if you just took what we proposed without any changes and passed it? To give you any level of useful data and certainty, I think is near impossible. As impossible as it is for me to ask you what will small group rates be in 3 years. And here's why. And I did speak to one of my favorite actuaries that the department uses. And it brings up a bigger point that understand that the additional flexibility for association health plans that we're proposing does not entirely just say, if you're on the small group, you can leave because of this. It allows current businesses that have not offered a plan to associate and now offer a plan. Maybe they're under 50, paying a small penalty, I think, to the state, but they've done the math and they're just not offering a plan, or maybe they're doing ICRA and having their individuals on the individual market. But there is a population of small businesses that simply do not offer health insurance. This would present an opportunity perhaps to do so. Then there are larger groups that are in ERISA currently, and that also presents an opportunity for them to, if it makes sense for them to save on their administrative fees in ERISA to associate. So I just wanted to make sure the committee was aware that this is not solely a plan that the movement is not solely about people leaving the regulated exchange. There's other shuffling that could happen because businesses want opportunities to save on administrative costs or otherwise. In terms of the data, so there's a lot of moving parts. Even if we change nothing in law, ERISA is, ERISA plans, self-insured plans, level funded plans are currently and always pulling people out and of an exchange plan, or people leaving those plans and going back in. Why would an actuary have difficulty giving us any level of certainty that I'd feel comfortable saying, yeah, here's what's going to happen in the small group market, and it's going to be in this range? And that's because you have to know everything about who the groups are that aren't insured, what their risk looks like, the claims experience, what the small group would look like by the time the earliest this could take effect in 2 years, what the impact would be, the natural impact of people migrating between or in and out of these different markets, and also what the price sensitivity is. We can get some information around that just by past behavior, but at what point do you refinance your mortgage? At what point do you decide to go, rate-wise is an analogy, versus at what point do you decide I'm going to leave the fully insured market?
Can I interrupt you?
Of course.
Isn't that exactly what actuarial science is?
Actuarial science takes,
Is that their job to?
their job is to, well, I don't want to speak for actuaries. They can model scenarios. They can say, it's hard to predict. First of all, like I said, they need the data. Actuarial science is, let's take data and determine what would happen. So I think a great example is what you're talking about in pharmacy, out-of-pocket maximum, right? There's actuarial values that need to be complied with. They can look at what kind of freedom and a plan, what type of space it gives in plan design to do other things to meet the actuarial value. But in terms of predicting where you as a small business, at what point, well, first of all, we'd need to give them the information. If you're not on the exchange as a small business or a nonprofit, or you're not offering insurance, we got to go find that data, and figure out what the overall market looks like.
Did you have a question?
Well, I guess I think yes, it's great that there's going to be opportunities for people, right?
Right.
Businesses, I get that. The conversation we've had around this table is though specific to the QHPs.
People leaving the QHPs.
People sleep. So can there be any type of estimate, something done on what it would do? Would it truly help small businesses that are currently buying on the QHP? And if it does, what does it do to individuals? I don't care about these people over here because they're not in the QHP.
I do.
I know, I mean, that's you know what I mean.
No,
I do
I
care about
do know
that,
what
but
you mean.
right
Right.
now, like, the point is, are we pulling people out of the QHP with this proposal? And if we are, who does it hurt and who does it help, and by how much?
Yeah. I still think that's a level of certainty, and checking in with his actuary, that would be hard to give a good reliable number on. It would, at the end of the day, to me, you do have to ask about the entire market, and you have to look at how much is it helping someone. And what I've acknowledged in testifying on this from the get-go is, yeah, there will be, just like there is now, every day, there's the opportunity for someone to leave the exchange and, through Arista or whatever, there's going to be a continued pressure on leaving what's possibly the most expensive exchange market for businesses in the country. Where I started with my testimony on this when it first was introduced is I'm no longer comfortable saying, no, you may not, because it's better for the common good. Or it's better for these people here. I mean, we're choosing winners and losers in an environment where you're looking for me to quantify exactly what the winners and losers would be in an environment where we have current winners and losers. We talk about them every day, but I don't want us to forget about businesses that just aren't even offering health insurance.
And I appreciate that, and I think that's where we have some key differences on
Yeah.
how we move forward with this, so I appreciate
Yeah.
that.
I would say that in the language as amended, you're not actually compelling us to do that study. And if
Not
you're,
right now.
yeah,
Yeah.
I would appreciate that staying that way, because I feel like that is, I feel like that's not going to give the certainty that we all would want in terms of what's going to happen. They're just, to put it very plainly, way too many variables for me to slap a study on the table here next year and be like, this is what's going to happen.
Can I ask a question of the committee? And we're not doing this yet, but I just want to get a sense, because I have a question for you. If I get a sense.
Yeah.
Is there anyone in this committee that if there is not a study, at least on the association plans, that they will not be voting for this bill? Can I get a raise of hand? If this bill contains exactly what is in this draft here
Around association health.
around association health plans, does that give anyone's pause on this bill?
I won't vote there.
I won't either.
It's a bit of a poison pill. if that's
So
what
here
you're
is
getting
my
at.
question, Commissioner. How do we move forward on this bill? Because there is some really good stuff in this bill, and I want to see this bill make it out of this committee by Friday. How do I do that? How can we come to a place where we can get this bill out of committee?
Well,
Are you, I'm asking, are you willing to do this study?
I'd need to get a little more detail than my 15-minute conversation with an actuary at 1:30 that I had at 1:30 to understand the art of what's possible here and the cost. This would not be a bill back. I don't think I can bill this to an insurer. This is not a cost neutral thing to our budget. furthermore, I think I don't want to be, I think it's fair to say that you guys don't like it anyway. I feel like I don't have this committee in terms of wanting to loosen up AHPs.
No, I don't think that's true. You know, I would not, yeah, and hold on though, because none of us said we didn't like it. We just haven't been presented with any clear information.
Right.
So we're not, I feel like a lot of us are not even able to make the determination whether we like it or not, because we don't have the data. And again, we're very concerned about what happens with the QHP market. And that gives us pause. And we feel like we really need to understand what we're doing to destabilize, if we're going to destabilize a market that we've worked tirelessly over the years to try to build and stabilize. So I don't think it's fair to say that we don't like it. We just, you haven't,
Yeah.
we need more information.
Yeah.
And I could step in. Sebastian Arguengo for the Department of Financial Regulation. In 2019, the Congressional Budget Office and Joint Committee of Taxation at the federal level tried to study this. And what they estimated was that studying the first Trump era expansion of AHPs would nationwide, in the aggregate, result in small group market premiums rising by 3%. But they did note, to the point that the commissioner is making, that that estimate was in the middle of an extremely broad range of possible outcomes, and that the projections were also, quote, inherently uncertain because of legal and administrative questions, and also that there were some aspects to the study, like how insurers, states, employers, and individuals all respond to the widening of AHPs that just could not be answered definitively. So I think if the question is, could we do a study? The answer is probably yes, but the number of assumptions we would have to make to do a study would make the answer you would get less like, this is exactly how much premiums would rise in the small group market, and more premiums would rise. It would be more like a Vermont snow forecast than
10 days out. 10
right,
days out.
10 days out.
That's great. That's a great idea.
I realize you have to study it, but you could model it. You could very easily say, okay, what if 500 people left the market? What if 1,000 people left it?
We could do that.
You could do that.
We could tell you, what if the healthiest 5% of small group market left?
Yeah.
That I'm not opposed to studying, or producing, because I think the cost of that is manageable and the uncertainties in that. I understand as much as all of you the importance of data. I love data. I guess my reaction to this overall is like kind of what Sebastian is pointing out here, is there's going to be such a variation in actually what will happen. So when I come back with data that says, if your healthiest 5% leave in 2028, here's what small group rates will be, there's still no idea whether that 5% is the right number, or whether no one would leave because it takes 2 years to set up an AHP and agree and shake hands, et cetera.
But at least we would have.
It's something.
Can I just say for the committee that I've asked, I know Lori has to go, but I've asked the speaker if we can have an extra 10 minutes, and she has given us that. So unless you feel like you need to go yourself, we have an exemption for 10 minutes.
Thank you.
Lori can't.
I think the other point I want to make, and I know I've made this before, is like that this is crushing, as you all know, everyone's working, and you mentioned it this morning, that the only sustainable way to deal with these issues is cost of care. And there's frantic work happening on cost of care. I'm not insensitive at all to the idea that there will be an impact on the QHP market in terms of the risk pool. This provides, but there's a lag on that, right? An insurer is going to have to see or try their best to predict who might leave, just like they did with the advanced premium tax credits, incorporate that into rates, see what actually happens. I would not be proposing this if I didn't think that in the interim, as this takes time to roll out, if it even rolls out at the federal level, that I'm less worried about that because I know that we're dealing with the systemic and root cause issues at the same time. So to answer your question, if the study is either gives us some flexibility in not breaking our budget and asking an actuary to predict human behavior, but just models certain scenarios like that, I do not object to that. You know, I don't have much of a budget for unreimbursable large actuarial studies. And frankly, because I think this is more of an issue of, are we going to offer this choice and help people now and react later if we have to, or are we going to need certainty in everything we do? I think that's a threshold question that we're on different sides of. So anyway, but
Do you have a sense of who and what percentage of insurances and exactly who those insurances or TPAs would be that underwrite the AHP plans? Do you know who we're talking about as far as the insured?
we have one major one now, and I believe they're with Blue Cross Blue Shield.
Okay. But we have one now, but we don't have do we have a sense of if other associations were formed?
Right.
Who the major underwriters are?
Underwriters meaning administrators?
Yeah, administrators. I'm worried about the rates that oftentimes are paid. I mean,
Rates to reimbursement rates to
reimbursement
hospitals.
rates, hospitals and providers. The hospital, non-hospital, outpatient, inpatient.
Blue Cross and Cigna do a lot of self-insured business.
Okay.
Do you have other thoughts on the market?
Yeah, I mean, in the self-insured market, we see a lot of issuers that are not participating in our fully insured market, like Humana, Aetna, United Healthcare. And even though their rates aren't subject to review by the Green Mountain Care Board, Vermont providers agreed to be in their networks.
Agree is a loose word. Go ahead, Topper.
Is there any appetite on this committee for studying what's actually happening? We leave the bill the way it was in the beginning, and we study what happens if the federal government changes. Because what this does is set it up in case or when the federal government changes their mind on something. So if they do, we're ready to go. We go, and then we look at, okay, what did happen? How many people did leave? Did the premiums go up for the people in the pool? Then we've got something concrete that we're studying. Right now, we're talking about actuarials trying to figure something out. And we set up a model. How the hell do we know that that model is going to be what actually happens? So to me, if you're going to have a study, that's what I think you should be studying. And if it comes out really negative to the people in the pool, then we figure out how to help them. I gave one idea. I don't know how many times I've said it. It begins with a C and it ends with a T.
Time out.
We could do something similar to that to provide a subsidy to those people in the pool if it was so bad that it was necessary. I want to study something that's going on and what the results of that are, as opposed to something that's fictional.
And I would call that kind of just live reporting from DFR in terms of the establishment or the approval. Remember, we have to approve association health plans, no matter what happens with this law currently in the future. So they come through us. And much like my testimony on short-term limited durations, we're not interested in approving things that don't make sense. But it also gives us an opportunity to see, to Rhett McFawn's idea, see and ask what the impact is. You want to form an AHP? What's your risk pool look like? What's your administrator predicting for your rates or morbidity relative to what you're doing now individually on or off the exchange? It's likely we would see potentially AHPs that combine potentially folks that aren't offering insurance now, folks that are on the exchange now, or, coming together to form a plan, insured or self-insured.
Karen.
So, when I was meeting with folks before I was appointed, I met with a lot of small businesses, and nonprofits, and they were just really concerned about not being able to offer health care to their employees.
Right.
Building businesses, restaurants, things like that. Would those folks be able to afford, like, what, if you modeled, like, what would it cost them? Would it be affordable? Could they offer them?
It would.
Is that one aspect that you could?
Yeah, and I believe that's why you see the coalition of support from the nonprofit and the BBSR and the chamber, I believe, for this. But I'm not going to tell you that it's going to make such a big health because of the cost of care.
Yes.
So being able to associate and have a different benefit and rate structure than the exchange can save you money. I would very loosely say, in the magnitude of making that decision 5, 10, 15, 20% over what you paid on the exchange. I think costs are so darn high, that's going to make a difference for some to say, all right, let's do it. Let's offer a plan. But for others, it's still so far out of reach.
And then part of it is, I learned today, we're not a shop. We don't have a shop situation, so that what you offered on these plans wouldn't have to, be the same as the Affordable Care Act. So, right?
Is that
Is that
correct? That what we would.
Could you
The question.
rephrase the question?
So the Affordable Care Act has certain requirements.
Yep.
These plans would not contain those same requirements necessarily unless we made them. Is that right? Or how would that work?
Yeah, so if you think about the ACA markets as having three big submarkets, that is the individual, small group, and large group markets. What is being proposed in H585 is to take the AHP out of that small and individual market framework and into the large group market framework in terms of coverage of essential health benefits and annual and lifetime limits and other consumer protections like that, which isn't to say that the large group market is completely unregulated. It's just to say that they have different consumer protections that apply to the market, because we assume that large groups are sophisticated purchasers who can make those kinds of granular decisions about the configuration of their health plans.
Yep. Okay.
Yes.
I'm just trying to think realistically here. We have 700,000 people, less than 700,000 people in this state. Most people do get employer sponsors. The rest of the people are probably, I don't mean the rest of the people, but if you take out all the Medicare and the people who are on supplemental and all the big business, it's not that many people. I just keep thinking, if we keep adding, keep throwing stuff at this system, that we're just saturating it and in a not good way. I think this would be the death knell for the Affordable Care Act. And I worry that people who have pre-existing conditions will no longer have a place to purchase healthcare.
Well, this would not change the pre-existing
The-
conditions.
I'm talking about the associated health plans.
that
They would
wouldn't change
not
the
have,
Pre-existing condition,
No.
protections, no.
so they can,
They would have to have an ACA compliant, they would have to design an ACA compliant plan.
exactly. Yes.
Right, so an
And-
association health plan, just to be clear, cannot deny a prospective employer coverage of their employees because one of the employees has a pre-existing condition. They
That's
can-
true? That's,
Yes, they can
I have not read
rate.
anything about these.
So an association health plan, like a large group health plan, could rate based on the morbidity of the group as a whole. But they couldn't deny coverage to a certain individual. Which, just to add some to the conversations that are being had here. In the self-insured market, what we do see in the stop loss plans that market relies on is that the stop loss coverage often does laser individual employees based on their health status.
But that doesn't impact the individual. That impacts the willingness of the employer to take the
Yeah.
risk to go self-insured or to stay in a fully insured, or,
So it would also have all the minimal essential
Yeah.
coverage then. So it's like
Yes.
QHP out of the market.
We need to go.
Okay.
I am so sorry. I completely forgot. We actually have a bill on the floor today.
Thank you for the time.
Thank you.
Thank you.
So,